All right, good morning, everyone. Welcome back for session 2 of your CMA program. Mr. Pugh, Ms. Watts, you have any announcements this morning?
Just one from me. I think everybody did the art, but please make sure you do the budget part as well. Our financial coach, Kevin Arndt, needs to schedule an appointment with you all, and we have to finish enrolling you all in the system. So, didn't do it, try to get it done today. That's all I have. Ms. Watts, you got anything?
All right, now that we're done with the announcements, we will get started. So, yesterday, I mentioned that the first thing we were going to do for each and every morning was to have a 30-minute quiz. And so, to prepare for the 30-minute quiz, I want to know what you each have done to review what we covered yesterday. And this is participation by all those that are enrolled in the CMAA program. So, who wants to go first?
Me. Oh.
Oh, and you changed your name. Look at that. It's a new day. It's a new day. We got a new president.
I'm gonna drink some coffee today.
All right. So, what did you do to prepare for the quiz today?
I didn't have a choice but to do some reading and some going overs.
Okay, so you reviewed the notes from yesterday, and I did send Mr. Pugh the recording. It probably wasn't until about 4 or 5 o'clock that I was able to send it to him. So, one strategy is to go back, listen to the recording, and fill in any notes or gaps in your notes. Because one of the things I think is important to note, you don't want to spend your entire class time taking notes and you're not absorbing the information. So you really want to be able to be present while we're covering the material so that when you go back and review, it's really a review. Okay, thank you, Mr. Ward. Next.
Before you finish, I have questions. Now, one, getting into the Zoom, do I have to wait on you, or like we had before, we had just some information that we could just get into Zoom? Because I'm usually on here like 5 minutes to 9, but I don't get in until you let me in.
That is correct. I must open the doors for you to come in. So yes, you will be in the waiting room because the way that Zoom operates is like a physical room where new people can't get into the room until the other people are out of the room. So at 8 o'clock this morning, I actually had another meeting in my Zoom account, and I logged out of there at about 8:45 to go get some tea, and then I came back over here. So to answer your question, you can't get in until I let you in.
Okay, now what about if you want to go back and study something later on? How do we do that?
So there is a place on YouTube that I have created for you to watch the recordings. So I sent it to Mr. Pugh yesterday. Not sure if he sent it yet, but let's see. We'll let him answer. Mr. Pugh? So did anybody get that link?
Well,
I
maybe I
had
did.
got it.
Okay.
I sent the link and I sent the study guide for chapter 1.
Okay.
Okay. So
I
that
received mine late.
okay. So that will be the place that I will always upload the recordings to. So you will use that same link each time to get to the place where the recordings will be housed. And for you old schoolers,
I don't know what you mean by that, but go ahead.
it's not like the 8-track or the reel to reel. It's an actual playlist. And so you click on the playlist link that Mr. Pugh sent you, and you'll see the recordings there, and they're listed by, I think I put them by date. I said old schools because my father has a reel to reel and an 8-track, and he will not part ways with them. And
That's because they work very well.
well, when he goes to heaven, they're gonna be sold very well. All right, to the highest bidder, not the lowest, but the highest. All right, I'm gonna pay my house off. Okay, so Mr. Ward told us his process. What about the rest of you? Because this train has left the station. It is the express train, and we're not making no stops until we get to the end. And when the end is when I get off and you continue to review and take your exam. So it's very important that you get a schedule together so that you can flow. So right now, everybody knows that that link that Mr. Pugh sent you, there, that's where I'll be uploading the recordings. It takes a couple of hours for me to put them there. Well, actually, it won't take a lot of time because now I've already set it up, and it's just a matter of us leaving this room, the recording generating, and then I just have to upload it there. So if you, a few hours after class ends, you can go there and check for the recording. Okay, so next up, let me go to my daughter's namesake, Jasmine. What did you do to prepare for the 30-minute exam today or quiz?
Okay, so I was kind of behind yesterday trying to get my scheduling together with the kids just getting back in daycare. So I kind of didn't study yesterday, just being honest.
Okay. Well, the first step is admitting that you didn't do it, which is fine because that just means that you figured out that you got to figure out how you're going to work the kids and do what you got to do so that you can.
Yeah, with them being back in daycare, it kind of fit the schedule now. So I'm kind of back on track. So yesterday was kind of like my get back on track day. So I'm prepared today. So.
Okay, sounds good. Next. And we don't have all day for you guys to figure out who's going to go next. So somebody go next.
I'll go next. Hello, good morning.
Good morning.
Yeah, I did go back and saw the video again. I didn't watch the whole thing because it's 2 hours, but yeah, I just went again and review it.
Okay. And then probably the first part of that recording was me introducing myself. So you could have skipped that part and got to the part where we started where after you introduced yourself and all of that. So, okay.
Yeah.
So
I'm sorry to interrupt you. I actually I stayed in your introduction and it got to me more. Like I have an admiration for you now.
Oh, but this is not about me. This is about
I know,
you.
but it just reflected on me. I was just like, oh my gosh, like I feel like there's a lot of speakers that don't come from the background that we do, and I mean, you're a success story, so I really appreciate that.
Well, thank you. But this is about you. Let's act like I'm not even here. This is about you getting some tools so that you can get a job and get some things that you perhaps want for your family, right? One of the many reasons that I kept going back to school was I had to make sure that I was always going to be able to provide for my daughter. I'll never forget when I first had my daughter, single parent, because her father was like, I don't know how to raise a disabled child. Well, she didn't come with a book, an instruction manual. I didn't know either. And my mother told me that she will never be hungry. And she was right, because my mother had instilled in me values of hard work and discipline. And so that has always been my motivation, was my daughter, that I had to make sure that she got the best care possible. I didn't want to be in a situation where she wasn't cared for, because I brought her in this world and she's my responsibility. So, all right, next person. Let's see who we got on here. I guess I have to call names.
Hello.
All right, that's right. That's right. Just go ahead. Start calling the
I
names.
didn't get to study yesterday.
No.
I had a flight to catch, and so I didn't make it here late. That's why I didn't see the email until later.
Okay, taking flights. I need to take me a flight. All right, so then what's your game plan for tonight?
Study.
Okay. All right. All right. Thank you, ma'am. Next.
I watched the YouTube video and I looked over my notes.
Okay. And when you looked over your notes, did you just look over them, or were you looking over them while you were cooking dinner, washing dishes, or were you sitting with the notes in front of you, reviewing and reflecting?
Yes, I was sitting and reading over my notes.
Okay. Because some people, they push play, they go cook dinner and do some other stuff. So you really you hearing it, but is it sinking in? Okay. Next. All right, Ms. Coleman. Ms. Freeman.
Well, I didn't get to study yesterday. It was a lot of family stuff going on. That's why I didn't get on yesterday. But tonight I'll make sure I study.
Okay. And Ms. Coleman. Is Ms. Coleman there? So one of the things we talked about yesterday was you all wanted to know more about working from home. And essentially, right now, you are learning from home, which helps you get set up for working from home. So rule number one, got to stay ready so you don't have to get ready. And that in this setting means figuring out what you need to do to get your schedule together. Because I'm sure, I don't know what this is called, Bridge 2 or whatever. I don't know. Mr. Pugh got all these fancy names, but you had that other part, and now you had this part, and this part is different, right, than maybe what you had before. So readjusting is critical. But when you're working from home, you have to be very disciplined. So if you're supposed to start work at 9 o'clock, my grandfather, who was 100, says, if you're on time, you're late. So you need to be in position, ready before it's time to start. So like, for example, at 8:59, the only person that was here was Mr. Ward. And then several of you trickled in immediately thereafter. So is 9 o'clock? Do we need to start at 9:08? 9:07, 9:05? You know, is there a barrier to the 9 o'clock start time? Mr. Pugh left. Uh-oh. So that's a no. So 9 o'clock is good. Okay, so being here and ready to rock and roll is critical. Same thing with work. You need to be at your desk, logged in, ready to work, so that when that clock strikes 9, that you're in the system and you're doing what you need to do. Okay, so yesterday we talked about several things. First up, we talked about the CMAA exam. So everybody knows, or you will know, that the exam is broken up into domains. And the domains are the result of a work group who got together and said, these are the tasks that a CMAA should be tested on, because these are the tasks that a CMAA does. So they came up with these 7 domains: scheduling, patient intake, office logistics, compliance, patient education, general office policies and procedures, and basic medical terminology. And so this work group said, these are the 7 areas that a CMAA should be able to do. And the material that we're going to be going through is going to break apart each domain and the tasks that you are expected to know under that particular domain. So for example, one of the areas is on following, under compliance, following Medicare's guidelines. And one of Medicare's guidelines is that you know how to report Medicare fraud. And so yesterday I mentioned that if someone has been excluded from participating in Medicare and Medicaid programs, that the organization should be aware of that and that they should respond accordingly. So each of these domains, when we start to talk about the tasks, the goal is that you understand how to execute the task and be able to answer questions about that task on the exam. The other thing I should mention, and I actually wrote the NHA and said this to them. I told them that I think it's time for them to update their exam for 2021, because the last time that they did a job analysis was around 2014. And things have changed since 2014, right? It's just like you heard Mr. Ward and I joking about a 8-track and a reel-to-reel. Some of you don't even know what that is. But there was an 8-track, there was a reel-to-reel, there was a cassette tape, there's a CD, and we had VCRs and beta and VHS. And today, all of this digital stuff, right? So I want you to be aware that I am aware that some of the stuff that you're going to see in your study packets, you're going to say, they don't do that anymore. And what I want you to understand is you got to answer the questions based on what they have in the study packet and what they say the process is, which may be different than what's actually happening in the real world today. So we're going to acknowledge that, and then we're just going to move on. Also, if you have any previous experience working in an office, you cannot answer these questions based on how you did it at your place, because this test is not written how you do it at your place. It is written how it's written. So we want to acknowledge that. We want to respect it because you want to pass the test. But in this setting, we also are going to talk about just again, the real world aspect. So yesterday we talked about the fact that you had certain questions under each domain. And so 19 for scheduling, 18 for patient intake, 12 for office logistics, 16 for compliance, 11 for patient education, 15 for general office policies and procedures, and then 19 for medical terminology. So what did we say about medical terminology yesterday?
Well, for one, you asked, did we have it? Did we still have the index cards and to keep studying?
Yes, thank you. So yes, you got to keep studying. And then here's the other thing. And you learned yesterday that I am a professional test taker because I have taken 11 national certifications, one which I did not renew because of the cost associated with it, which is the certified medical assistant. I just could not continue to pay for that renewal and pay for the ones that reflect what I'm doing today. But I'm a professional test taker, so I know how to take tests. And the one thing I want you to be very clear about is you have this packet of terms that you're studying, right? But there may be some terms on there that you have not seen before. And so I will give you some additional terms in addition to what Mr. Pugh and Ms. Watts gave you to add to what you already have. And the way that you take tests is you have to know the material so that you can apply it to a question. So let's say they give you a medical terminology question. There's 4 multiple choice answers. Let's say you read the question, you look at the 4 answers, and you don't know which one is the correct answer. Well, the first thing you have to do is eliminate what you know is not the answer, because you know. So for example, let's say the question says, let's say, one second, I gotta let Mr. Pugh back in. Let's say the question is, what is a small fixed amount that is paid to the office at the time of service? What is a small fixed amount that is paid to the provider at the time of service? And then the answers are deductible, coinsurance, premium, and copayment. Well, yesterday, if you were here yesterday, you know the answer is
Copay.
copayment, right? So in order to answer that question, you would need to know what premium, deductible, copayment, and coinsurance all mean so that you can attack the question. And so you basically need to eliminate by recalling what those definitions are and eliminate the ones that you know are wrong to back your way into the correct answer. Okay, so questions on the CMAA exam. And the reason that you're going to have daily exams, and if you notice, I haven't whipped out an exam yet. And that's because I know I've been teaching since 97. And I know some of you had to get adjusted to this new trainer, this whole setup. And so I'm giving you some grace today and not giving you a quiz so that you can be ready for the morning. Because you have all of your tools. You're going to work on what you got to do with your little peoples, your dog, cat, whatever, so that you can be ready for the morning. You know where the recordings are, etc. So questions on the CMAA exam. I usually like to talk about this earlier in our sessions, meaning like session 1 and 2, and then we don't really talk about it anymore, and we just focus on the domains. Did Mr. Pugh and Ms. Watts tell you that the exam is on the computer now instead of face-to-face?
Yes.
And you are aware of what that environment is going to look like?
Like nobody can be around us or near us. Like it has to be like somewhere secluded.
Mm-hmm. Yep. Mm-hmm. Because they're going to want to check your surroundings and just make sure that it's just you sitting there taking the exam. All right. Well, enough about the exam. Let's talk about the revenue cycle. How many steps are there to the revenue cycle?
There's 10 steps.
10 steps. All right. 10 steps. All right. So let's review those 10 steps. And we're going to take them a little bit more detailed today than we did today. So the first step involves scheduling the patient for an appointment. And in the real world, scheduling can take place via a computer, or it can be written in an appointment book. That's real old school. When I first started, we didn't have a computer. We had an appointment book. So in the office setting, the scheduling process, whether it is paper scheduling, which is called a book scheduling, or computer scheduling, requires that we have some type of format that we use to actually schedule our patients. And when we say format, Mr. Ward, we're going to take it back, way back to the days of the Fantis Clinic at Cook County Hospital, the one where they had the little food truck outside, the one where everybody had an appointment for 8 o'clock.
Yes, they did.
And 8 o'clock was your appointment time, and so was everybody else's. And we figured out very early on that they really was seeing us in the order that we was arriving and signing in on the sheet. So we got there early, crust in our eyes early.
Brown paper bag in our hand.
Yes. And we waited and we waited. And eventually we were seen. Now, I haven't been down there. I used to work there 99. I know one of them winters, it snowed so bad, I decided I couldn't work there no more. Outside of, I didn't want to deal with the union employees anymore. It took me 5 hours to get back home. So, because of the snowstorm. So the format that they use that particular time was where everybody got the same time and they took you in the order that you were seen. Now, I did later learn that they also had a process where they may say, okay, your appointment is at 9 o'clock. And then the next group, okay, you 9:15. The next group, you're 9:30. Okay, the next group, you're 9:45. So they had people coming in waves, right? But still, it was still the same process. You were seen in the order that you arrived. You signed in on the sign-in sheet. Now, back then, we didn't really have HIPAA privacy, right? Because I'm nosy. So I signed in. I'm looking at who else is signing in on this sheet, right? That's a violation of patient's privacy. And so today, things have changed when you sign in because we want to protect patients' privacy. So there are various approaches that they use, which include putting your first name down, and it's a little sticker, and they pull the sticker off and get you checked in, right? Or they have one piece of paper that you write on and turn it in. Various strategies that they use to try to protect the patient's privacy. Because, y'all nosy. You signing in your name and, you just looking down. Who else is here? Especially if you put last name and first name and it's a community clinic, if you see somebody's name that what's the first thing you're going to say?
What they here for?
Yeah, I see Miss Latasha. Is she looking like, I want to know what they here for, especially if you suspect that they got some things that they be doing, risky behaviors. You like, I wonder if they got something, right? So we have to protect the patient's privacy. So in your review packet that Mr. Pugh gave you yesterday, it talks, which you need to read several times. Each packet that Mr. Pugh sends you, you need to review several times. So in that packet, they talk about the fact that there are 6 types of ways to schedule a patient. Those 6 types, and I don't know how you guys take notes, but I'm an old school learner and I like to do outlines. So as it relates to scheduling the patient, there are 6 types of what they call booking processes. 6 types, which we'll talk about them later, but right now we're still reviewing the revenue cycle. Because I want you to live and breathe these steps. So, all right, now we got the patient scheduled. And again, various ways to schedule the patient. Some places have where you just walk in, like Howard Brown has a Howard Brown, Family Christian, Aunt Martha's, some of our neighborhood clinics. They have a walk-up clinic where you can just walk up, sign in, and be seen. Usually, you do that for, you got a cold, you have an itch. Mr. Ward, don't look like that. It's very popular in the nursing homes today, sexually transmitted diseases, just FYI. It's not just the young folks.
Yeah, that's too much information though.
But that's real world. Yes, so Sexually transmitted diseases, cold, upper respiratory infection. That's generally what you see in the walk-up clinic. And that's just open, right? Where you don't have to make an appointment, you just come in. All right, so the patient is scheduled, and the next step is we're going to get them registered. We talked about yesterday how registration can be before the visit. We call it pre-registration. And during that pre-registration time, we're going to collect some demographic information. And the demographic information is about the patient's name, address, insurance information, where they work. Yesterday, we talked about some things to remember regarding the patient's insurance. And so we talked about the importance of verifying the patient's insurance at every visit. And why do we want to verify the patient's insurance at every visit? Somebody other than Mr. Ward, because I know he took good notes. And he's selling those notes for $25 for the first page and $50 for each additional page.
Sound like a plan to me.
To make sure they insurance is like still valid, so they don't have to like pay out of pocket or anything.
Yes, because if the patient does not have health insurance today for the visit, they're self-pay. And self-pay means we are collecting the payment at the time of service. Okay, so yesterday we talked about, as it relates to insurance, we talked about the word co-payment and co-insurance. Co-payment was a small fixed amount. And what is co-insurance? Somebody other than Mr. Ward. I don't know Jasmine's last name, but Miss Jasmine. So what is co-insurance?
Co-insurance is a percentage the insurance pays for the patient.
Yes, so I want to add to that. Co-insurance is a percentage that is paid by the patient and a percentage that's paid by the insurance company. So, for example, yesterday we talked about Medicare. And Medicare has a co-insurance requirement for office visits. Medicare pays 80% and the patient pays 20%. And together that equals the 100%. Now, it is not 100%, a true 100%. And let me explain why. Let me get my calculator out. So let's say that, okay, let me get my calculator going. Let's say that we have a patient who is in the office today. They are a new patient, and we, the office, charge $200 for that office visit. Are we going to get paid $200 for that office visit from the insurance company? Okay, I see Mr. Ward shaking his head. No. And why, Mr. Ward? Why aren't we going to get paid that $200? That's what we charged.
Because a whole lot of other people are going to take money out of it before you get the end result.
Sort of, yeah. So this is what happens. And we're going to just isolate Medicare. Medicare does not care what we charge. Medicare is only going to pay based on what they allow for that service. What they allow for that service. So we charge $200. Medicare allows $160. Okay, so we charge $200, but Medicare only allows $160. Medicare then says we will pay 80% of what we allow, and the patient pays 20%. And together that equals 100%. So let's do the math. We charge $200. Medicare don't care about that. Oh, excuse me. They allow $160. Medicare pays 80% of $160, and the patient pays 20%. So let's do the math. $160 times 80% is $128. $160 times 20% is $32. And if you add 128 plus 32, that gives you 160. Everybody follow me? Now, somebody got to ask a question, because I know you got a question about something, about this $200, and now we got this 160. Your question is going to be, what about the, I see Miss Natasha, she wants to ask.
What about the $40?
What
The
about,
rest is what?
yeah, well, what about that? Yes, what about that? We write that off. Yes, we write that dollar amount off. And that was like, oh, wow. So you know how everybody thinks the doctor's offices and the physician offices are making all this money? They're not, because what we charge is not what we get paid. And what about our expenses? What expenses do we have, or do they have? Not us, because we don't own the place, but what expenses do doctors' offices have? We talked about this yesterday.
Like the supplies they need in the office, it's like
What's their
gloves,
biggest
masks.
yes, but what's their biggest expense?
Paying me.
Paper.
People, yes, paying their employees. That's their biggest expense. That's their biggest expense. Got it? That is their biggest expense. So they got to pay you, and you want them to pay you, right? Because you've been working hard every day, 5 days a week, right? 40 hours, 80 hours every 2 weeks. So you want them to pay you. But in order to pay you, they got to get paid, right? So they're paying you, and then they're paying for supplies. They're paying for equipment. What else they paying for?
Rent and light bills. And all that
Right.
stuff.
So
Yeah.
the hospital probably got a mortgage on the building, right? They got insurance. They got taxes. So they have all of these, what we call operating expenses. And you got to pay those, right? Because if you don't pay your lights, the patients can't come to the hospital by candlelight. I guess they can, but how the equipment gonna operate, right? So some of it has a battery backup, but that battery is not going to last for months and months, right? So they got to keep their bills paid. They have to have supplies. Today's environment, they got to have PPE. So they have all of these expenses. And so what we charge is not what we get paid, but what we are supposed to get paid, we need to get paid that dollar amount. And that's what the revenue cycle is about, is making sure that we collect all of the information at the time of service. We verify the information at the time of service to ensure that when the claim gets submitted, that we can actually get paid. Okay, so we're talking about the 10 steps of the revenue cycle. And we talked about scheduling, we talked about registration, and I mentioned co-insurance, co-payment. And now I'm going to add 2 words to that equation. And you heard me say them a while ago, which are premium and deductible. Who has a car? Raise your hand. Well, I know Jasmine got a car because she was just in it. All right, so with your car, you need car insurance, right? And in order to get your car insurance started, what do you need to pay? You know what that's called? Not just money that you pay. There's an actual name for it.
That's the premium.
That is the premium. So that's what you pay monthly, every 6 months, yearly. That keeps your policy, what's the word? Active. What happens if you don't pay your premium?
They cancel the policy?
They cancel the policy. All right. So everybody understands what the premium is? That's what you pay to get the insurance and keep the insurance active. It's the same with health insurance. Now, if you are employed full-time by an organization or even part-time, the premium is paid to the insurance company directly from your employer. But you, as the employee, pay a portion of that via your payroll deductions, right? Okay. There have been situations where the employer didn't send in the premium and the insurance was canceled. So a patient presents to you today with an insurance card. You want to verify their eligibility each and every visit, because if you don't, you could find, while they had insurance last week, it terminated and they no longer have it this week. And if they don't have the insurance this week, they are self-pay. Okay, so premium keeps the policy going. What happens if you have a car accident? What do you have to pay to get your car repaired?
The deductible.
$500 deductible.
Okay, I'm glad, Mr. Ward, I'm glad you said $500, because in the insurance world and the car insurance world, the deductible that a patient pays has a direct relationship with the premium. For example, for my car insurance, my deductible is $250. Why? Because we pay more per month. Because in the event we have a car accident, we can come up with $250. $500 is a lot of money. The $250, you could borrow 50 from 5 people and you got $250. So same thing with insurance. There are different packages that somebody could purchase. And this is going to get even deeper than what we're talking about today. But one of the things I like to do is repeat some of the same information over and over again. And I just want it to be something that you live, breathe, eat, sleep. And I want you to be able to go on an interview and have a conversation with the person who's interviewing you like you've been doing this for years. So when patients select their insurance plan, if they're in an employer-sponsored plan, you got different options. And you know how with the Olympics, they have like bronze, silver, and gold? Well, the insurance plans are like that as well. And they're like that because it allows the patient flexibility to pick the plan that fits into their budget. So the more that you pay for your premium, the lower your deductible. So you could have car insurance, your deductible can be $100 if you want it to be. You just have to pay more for your premium. So deductible, let's talk about that. The deductible is the dollar amount that you pay before they pay. So in healthcare, and let's go back to our Medicare example, Medicare patients for Medicare Part B. Anybody remember what Medicare Part B is? Talked about it yesterday. So Medicare has 4 parts. Write this down. 4 parts. Part A is for hospital insurance, inpatient care. So inpatient, skilled nursing facility, and some home health services. So inpatient hospital, skilled nursing facility, and home health. When a patient is eligible for Medicare, they are automatically enrolled when they do their paperwork in Medicare Part A, inpatient hospital services. Medicare Part B, however, which covers physician services, outpatient hospital services, some home health services, equipment like oxygen tanks, walkers, wheelchairs, canes, that's Medicare Part B. And so essentially, Medicare Part B covers services that Medicare Part A doesn't cover. So A, inpatient hospital care, skilled nursing facility, some home health services. And then Part B covers physician services, outpatient hospital, and some home health services. So when a person is Medicare eligible, they automatically get Part A. Part B, however, they have to enroll into Part B. And Part B requires that they pay a monthly premium. This is where Mr. Ward is going to be the liaison for the patients that are going to be, that might be your hustle, Mr. Ward. You have to have multiple streams of income. So for Medicare Part B, you have to pay a premium, a monthly premium. And watch this, guys. Medicare is smart. Medicare takes that money right out of the Social Security check, that monthly premium. Why? you know how we juggle our money. Okay, I'm not going to pay this one right now. I'm going to pay this one instead. And Medicare does not allow you to make that decision. They take that money right out of your check. Now, how much the patient's premium is going to be based on their income. So if somebody's income is like less than $88,000 a year, their monthly premium is $148 a month. A month. And again, Medicare is smart. They don't let you decide when you're going to pay your premium. They automatically take it out the check. And that monthly dollar amount will go up based on how much money the person makes. So for example, let's say Mr. Ward makes $500,000 a year. Mr. Ward would have to pay $504 a month for his premium because it's based on income. So one of the things that a lot of people don't think about is what life is going to be like at retirement, because you don't just retire and move to Florida and life is good. You got to plan for that, right? And you can't plan for it when you turn 65. You got to have been planning for that, right? So that premium, Medicare automatically takes it out, but you have to enroll in Medicare Part B. Medicare Part A and B combined are known as the traditional or the original Medicare program. So about 20 years ago, Medicare came up with Medicare Part C. And just like they do with all types of things that are, I call, politically driven, they originally called it Medicare Choice, Medicare C, Choice, right? And the reason they called it Choice is because they said, hey, Medicare patient, we want to give you a choice when it comes to your health insurance coverage. Because if you notice, when I mentioned Medicare Part A and Medicare Part B and the services that are included, not once did you hear me mention medication. And if you know anybody who has a chronic illness or is older and is on medications, those medications are not cheap. So the original Medicare program does not cover medication. So Part A and B, medications are not covered. So patients go various routes to get prescription drug coverage. They get a job, a greeter at Walmart, and they can get some insurance that way. Or they're watching TV and Bob Barker comes on TV and talks about a supplemental insurance plan that you can buy to cover what Medicare Part A and B doesn't cover. And some of you are like, who the heck is Bob Barker? It was just some superstar person that they put in the commercial, somebody that the people in his age group could identify with. And they said, well, if Bob Barker says that that's a good thing to do for him, it's a good thing to do for me. The reality is Bob Barker doesn't need no supplemental plan. So I'm gonna bring it to modern day. Let's say, this wouldn't move me, but some people would move. Let's say Beyonce is on the TV and says, are you struggling to pay your prescription drug coverage? Why not sign up for this supplemental health plan for a low price of such and such per month? And if you are a Beyonce fan, you believe Beyonce, and you're like, I'm going to get that because, yeah, my inhaler costs a lot of money, right? However, you and I both know Beyonce don't need to buy no supplemental insurance. Beyonce can buy an insurance company and a whole team of medical professionals, but they do those commercials to appeal to people. So patients have a decision to make about how they're going to get prescription drug coverage. So Medicare came up with Medicare Part C. They originally called it Medicare Choice. Today, it's called Medicare Advantage. And Advantage plans are offered by private insurance companies. So remember I told you yesterday, the man that wanted to meet with my mother, he was a Medicare Advantage rep. And what he was trying to do was to get her to switch from one Medicare Advantage plan to another. That is until I told him, or I told her that I'm going to the meeting with you. And then he canceled the meeting. That's the one at the Panera Bread, because I would have been able to ask him questions about why does she need to switch to this plan. So Medicare Part C combines Part A, Part B, and it gives prescription drug coverage to some extent. And the patient is assigned to a primary care physician. And essentially, it's an HMO plan. Let's just stay right there. HMO, Health Maintenance Organization. If you have an HMO plan, you are assigned a primary care physician who is also known as the gatekeeper. And why is he the gatekeeper? Because you can't get stuff done without going through him, because he is receiving money for you being on his list, and it works in his benefit if you only see him. That's what the gatekeeper is. And if you need to see a specialist, guess what they give you? If they want you to have one, is a referral. And if you don't get this referral to go see the specialist, your visit won't be covered. So during the scheduling and registration process, when we're verifying the patient's insurance, if we are a specialist, let's say we're a cardiologist, if we are a specialist, we must have a referral for patients that are HMOs. If we don't have that referral, we got, on the date of service, we got two choices. Send the patient home, or have the patient wait while we sit there and try to obtain the referral. If we see the patient without the referral, there's a strong possibility that we're not going to get paid for that visit. It is not better to ask for forgiveness afterwards. If it is something that we need in advance, we have to get that paperwork in advance. So verifying the patient's insurance is more than just, yes, they have coverage. We need to know what type of coverage they have. For example, if we're working in an office and the patient only has Medicare Part A, do they have coverage for the office visit?
Maybe not.
Right, because Medicare Part A, what does Medicare Part A again cover? Inpatient hospital services, skilled nursing facility, and some home health services. Medicare Part B covers physician services, outpatient hospital services, some home health, and durable medical equipment. So walkers, wheelchairs, canes, oxygen tanks, stuff like that. So if a patient is in our office and they present to you an insurance card, Medicare card, that says Medicare Part A, at this point, your question to the patient is, do you have another insurance to cover your office visit? Because Medicare Part A only covers inpatient hospital services, skilled nursing facility, and certain home health services. So you ask that question to allow the patient an opportunity to tell you what other plans they have. If they have no other coverage, what is their classification now? Starts with an S.
Self-pay.
Self-pay, yes. So in our systems, usually at the very top, when we pull up the patient, you'll generally have, the name, date of birth, gender, and right over across from there, it says financial class. Financial class. Medicare, old school Medicare, Medicare Advantage. Now, as it relates to Medicare Advantage, there's different types of Medicare Advantage. Remember I said for Medicare Advantage, which is Medicare Part C, that this is where you have private insurance companies that are working with Medicare patients. See, these are private companies working with Medicare patients to offer a plan that combines A and B. So if they don't have that, then their financial class, again, is self-pay. So Medicare A, B, C, and now we have D. So in 2003, I believe it was 2003, whoever was in office at that time, I don't remember, maybe Bush, came up with this initiative called Medicare Modernization Act. They wanted to make Medicare more modern. They call it the MMA. And as a part of the MMA, they established Medicare Part D. I say D for dumb, but it's actually D for drugs. And people thought, yes, finally, Medicare cares, because they are now offering a program that covers prescription drugs. But everybody should know that everything that looks good, sounds good, isn't good. So Medicare Part D is, it was the Medicare Modernization Act of, I want to say 2003, but the program wasn't available until 2006. So what it is an optional plan that requires, watch this, a premium. So the minute you tell me I got this plan and now I have to pay yet another premium, you lost me. So with this premium, this is a program that's offered by private insurance companies. If you didn't like insurance companies before, you probably are going to hate them now. But this is offered by private insurance companies. Patients have to pay a premium. And the premium goes directly to the insurance company. And that's all we're going to talk about that at this point. So A, B, C, and D. When you're verifying the patient's insurance, you need to take into consideration where you work, what services the patient is going to have at your place, so that you can make sure that the insurance that they have aligns with your clinic or your service. Because if they got Part A and you in the office and they don't have any other coverage, they're self-pay. So eligibility is more than just, yes, they have insurance. You need to find out to what extent, what do they actually have coverage for? For example, let's say you work for a chiropractor. Yes, the patient has insurance, but does their insurance cover chiropractic services? If not, what is their financial class?
Category S.
Self-pay, right? And when they are self-pay, when do you want them to pay you?
As soon as they come in the door, before they take their coat off.
Right then and there.
And why?
For you to see the doctor, in order for you to see the doctor.
And
So when they leave, you have your money before they put their coat on and go.
Oh, yeah.
that's it right there. Patients are more vulnerable before they get what they need, right? Case in point, you got this boil under your arm and it's hurting. Woo, it's hurt. It's red, it's hurting. You vulnerable, right? Because you need this off. You done tried to put some remedies on it, Vicks Vapor Rub, Windex. You done tried all kind of the old school remedies. Vicks Vapor Rub does work for a lot of things. But anyway, you tried that stuff. You done took painkillers, and this thing is now it's red, it's pussy, and you need a professional to remove it. You vulnerable at that point, and so you self-pay. And if we are a organization that is private, that says if you don't have insurance, you must pay today, we collect that money. Because once this is taken care of, guess what? You good, you out of here. So you're most vulnerable before. Now, I mentioned yesterday that there are some clinics that see patients based on their that don't have insurance. And in our system, we still classify those patients as self-pay, but we may not necessarily be collecting money from them. So I mentioned Howard Brown, Family Christian Health Center, Alivio Medical Center. I'm trying to think of all the places where you guys might be close to you. So close to me is Aunt Martha's. Aunt Martha's, Family Christian, Access. And then if you go into like by Kennedy King is Howard Brown, Miles Square, Beloved Medical Group. Those are federally qualified healthcare centers. And those are great places to work, by the way. So if it's that type of setting, then they may not collect the money. Okay, so everybody understands Medicare Part A, B, C, and D, and premium, deductible, co-payment, and co-insurance. Yes? Okay. All right. And we talked about the importance of verifying the insurance at the registration part, something we have not discussed. And some of the things, so let me just tell you, some of the things I'm discussing right now may or may not appear in the study packet that Mr. Pugh sent you because the study packet is specifically for the exam. Our classroom meetings are exam and real world, because after you take the exam, that's over. You got to deal with the real world. So real world, during the registration process, when we're intaking our patient, we ask for a copy of their ID and their driver's license. And we compare the two to make sure that it's the same name. And then we are verifying the insurance, and we're going to take a copy of the front of the insurance card and the back of the insurance card. Why are we taking a copy of the front and back? And if you got an insurance card, anybody got an insurance card handy? Pull out your insurance card and take a look at the back of it.
Don't the back have like the vision and like where you can go for other places that take your insurance or something like that? Like the front have your Medicaid number, your Medicare number and stuff, like your information on the front.
Anything else? Anybody got the insurance card?
One side has the name and the other side has the number, the ID number and stuff. The medical and ID number.
Okay, we're getting close. So generally on the front, you have the patient's name, who's eligible, what your co-payments are. And on the back, we have the information that we need to send the payment to. Because remember I said yesterday that you could have multiple patients with Blue Cross Blue Shield of Illinois, and they have different coverages and different requirements. So on the front, they could both say Blue Cross Blue Shield. And on the back, it may say send to this address for one plan, and for the other plan, a different address. On the back, it may tell you to call this phone number for this particular patient and that phone number for a different type of patient. So if you don't copy the front and back, you don't have all of that information. And when the patient is gone, if you are at step 10 and you're trying to appeal the claim, you need to know what number to call. Make sense? So that information on the back is critical. Why we need that ID?
To make sure it's you.
Yeah, because guess what? Back in the day, if you didn't have insurance and your friend had insurance and you was a girl and she was a girl, you just take her card and you go and get treated for your chlamydia and get your prescription and you're going on about your business. But this is the problem, and you're going to learn about this. Step 4, we code the visit. We assign diagnoses and procedures. That diagnosis becomes a part of the patient's permanent health record. It is in the computer under their name, their social security number, and their date of birth. So now you have what that person have that you let have your insurance card. And people didn't know that. And so years ago, I contacted State Farm about life insurance for myself and for my daughter. For me, they came out to the house. This is when they came out to the house. They came out to the house, took some blood, measured my blood pressure, weighed me. And for my daughter, they just asked for her social. A few weeks later, I got 2 envelopes in the mail, one for me, one for her. And it said for me, you are approved at this higher dollar amount because of your weight. And then for your daughter, denied due to profound sensory neural hearing loss, denied due to every condition that she had, they knew about because claims that had been sent to the insurance company with her name on them had all of her diagnoses. So when people lie and say they haven't had something, if it has ever been captured, it is in the system under your name. Sometimes people will lie and say, no, I don't smoke. And then they do a chest x-ray and then they learn you do smoke. So yeah, sharing insurance cards, not a good idea because of that reason. Again, today, we asked for the insurance, we asked for the ID, and we get a copy of the front and back of that as well. Okay, so a lot of stuff going on in steps 1 and 2, and we have just touched the floor of what happens and not the ceiling. There's even more than what we're talking about. Okay, step 3, the patient arrives or the patient now is seeing the doctor. And the doctor is going to document the patient's visit. Let's pause for a second because I want to pull up a visual. Okay, I guess I was doing all that talking and you didn't hear me, huh? So let me start over. So where we are at this point is that the physician has seen the patient or has seen the patient and has documented their service. And the service is documented in a format known as SOAP, SOAP, SOAP. S is for subjective. That's what the patient says is what's wrong with them, why they're there today. The O is objective, objective. That's what the physician is finding based on him talking with the patient and evaluating the patient. The A is the assessment or the diagnoses. And then the P is what he plans to do about it. Everybody got the SOAP format? Of note, SOAP is actually...
Wait, I'm sorry. Could you go over one more time? I'm sorry.
Okay, so S, subjective. What the patient says is what's wrong with them. O, objective. What the provider has found to be what's actually going on based on him examining the patient. The A, assessment. That's the diagnoses. And the P is the plan, what he plans to do about it. So in the chat area, I have provided a copy of 2 patient office visits that are documented in a SOAP format. SOAP is a term that you are expected to know for the CMAA exam. It's under medical terminology. So I put the 2 office visits in the files and in the chat box. Were you guys able to download it? You just have to click on it and then, or do whatever your device tells you to do next. Now, if you're on a cell phone, I don't think it's gonna pop up. I did send them to Mr. Pugh, but I'm not sure if he saw my email and sent it to you. And if not, that's okay, because I have it up on the screen. Okay, so now that we're done with that, I want you to take a moment to read the note that's up on the screen. If you have it on your computer, if you don't, I have it up. So let's, for those of you who weren't able to download it, you tell me when you're ready for me to scroll down some more. So office visits notes are generally written in the SOAP format, and I told you what SOAP was. But tell us a little bit about Quincy Lampin, our 5-year-old patient.
Well, for one, he has type 1 diabetes. I think his mother lets on there's more problems with him than it is. And everything else with him is kind of normal.
And we see what medications he's on. So he has type 1 diabetes. He is on insulin. Usually type 1 diabetes are on insulin. And he examined him. And what was the end result? What was the plan?
Long-term insulin use increase, what's that, Levomar to 6 units at night.
Okay, so based on this first patient, you see the subjective coming in today to follow up on the type 1 diabetes. From there, the doctor starts to give his portion, what he's finding out from his interview or conversation with the patient. So he, they've had it for 5 years. The mother and the father is telling the story. So they're going to tell you, their version, maybe not what they're not doing at home. But anyway, this is what they're saying. He examines him and says, we're going to increase the insulin. So you got the subjective, the objective, the assessment, and the plan. Now, let's compare that to Daphne Mellons. How does Daphne differ from Quincy? Another volunteer.
This a child?
Well, they're both children.
Oh.
So Quincy is 5 and Daphne is 2 months old.
One is a baby.
But what's different about the visit?
She's not diabetic. They're seeing how much movement she has.
What else?
This just like a checkup, a wellness visit?
Yes. So Daphne is a wellness visit. Quincy is what we call a problem-oriented visit. Problem-oriented visit. So Quincy, he has a problem, which is diabetes. Daphne, she's just coming in for her preventative medicine exam. And if you have kids, what else happens during these exams?
Shots?
Immunizations, yes. All right. Okay, so let's go back to our steps in the revenue cycle, because I don't want you to just hear the steps. I want you to have an understanding of what those steps are. Okay. So we had the patient visit, that's step 3. Step 4 is where the services are coded. There are 3 coding systems that you should be familiar with. And this is for the exam as well as for the workplace. And we haven't even gotten into where we're just going to focus on scheduling, focus on patient intake. Right now, we're just talking about it from a big high level perspective so we can break it apart. So coding, medical coding, that's step number 4. There are 4 systems that you should be familiar with. I'm going to type them in the chat box as well as say them. The first one is CPT. The second one is HCPCS. The third one is ICD-10-CM and ICD-10-PCS. So those are 4 coding systems. Coding is where we take the words and we turn them into numbers, okay? We take the words and we turn them into numbers. Still following me? You will learn what these abbreviations mean later. Right now, we're just building awareness. Okay, so in our previous 2 patients, one had a problem-oriented office visit. The other one had a preventive medicine visit. Those 2 visits are captured and reported to the insurance company using a CPT code. So our 2 patients, one had a problem-oriented office visit, the diabetes. The other one had a well child visit, also known as a preventative medicine visit. And both of those services are captured by a CPT code. Everybody follow me? Both patients at the end had final diagnoses. Our diabetes patient was a type 1 diabetes patient. Our little 2-month-old had a well child exam, and there is a diagnosis code for a well child exam and diabetes. The diagnosis codes are ICD-10-CM. 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 Okay, so let's pause for a second and compare the 2. CPT shows what they did. ICD-10-CM shows why they did it. CPT, what they did. ICD-10-CM shows why they did it. Everybody still follow me? So for Medicare Part B, in the office for the physician services, we're going to report a CPT code and an ICD-10-CM code. That's the coding process. The little baby also had vaccinations. The vaccinations are reported with a CPT code. Everybody still with me? Head nod. Okay. The other 2 systems, HCPCS. Remember earlier we talked about walkers, canes, wheelchairs. Remember that? Medicare Part B pays for durable medical equipment. HCPCS codes are what we use to report durable medical equipment. Walkers, wheelchairs, canes, crutches. We could also use it to report ambulance services. What else I could think of? Oh, you know when a person gets IV fluids, like they're dehydrated and they hook them up to an IV, HCPCS codes also have a code for IV fluids. Okay, the 4th system, ICD-10-PCS, is used for inpatient hospital services. So if you're working for the physician, you will never see ICD-10 PCS codes because they're only used by the hospital for inpatient hospital services. So coders take the words on the SOAP note and they turn them into words. Everybody still with me? Okay. Step 5, the codes are keyed into the system. And in order to do that, of course, you got to pull up the patient. You pull up the patient, and then we put the codes in for today's service. The CPT, guys, is the moneymaker. The diagnosis code is really just about medical necessity. All right. So step 5, we put the charges in. So let me stop sharing for a second because I want to pull something up to show you. And everybody still follow me, right? Okay. So the next step, step 6. What's step 6? Anybody remember?
What was the question? I'm sorry.
What's step 6 for the revenue cycle process? So step 5 was the charge entry. So what's step 6?
Is that policies?
No.
No.
Okay, let me go back to the other screen before we move here.
Is it
Charge
general
entries?
just
Charge entries?
So charge entry is step 5. So we got the charges in the system. So they were coded and they were entered into the system. The next step is the claim scrubber.
Right, scrubbing claims, right. You're right.
Okay, and what does the scrubber do?
It's like the clearinghouse.
It checks for errors in the coding process.
Coding, registration. So remember the baby who we just had that was 2 months old? There are CPT codes for preventative medicine services that are divided by age. So the code that you will report for that baby wouldn't be the same code that you will report for like me, right? Because I'm not 2 months old. Okay. After the scrubber system checks the claim, so if you say the baby is 2 months old, but you use a code that says the baby is 4 years old, what does the scrubber do?
It checks behind it to see which is the right entry.
And what's the
Correct.
goal of the scrubber?
Is to put in the right entry.
And what do we want at the end? What's our end result?
Get paid.
Yeah. What does your washing machine do when it scrubs your clothes?
Cleans them.
Yes. So the goal is to scrub the claim so we can have a clean claim. And a clean claim is what we submit to the insurance company. Because if it's clean, hopefully we're going to get paid. That's our goal. Okay. So the next step after the scrubber is to send in the claim. This is a picture, a portion of the claim form. This claim form is called the CMS 1500 claim form. The CMS 1500 claim form. This is the claim form for Part B services. So CMS 1500, this is for Part B services. We have another claim form that's called the CMS 1450, and this is for Part A. And what am I talking about Part A and Part B?
Going back to Medicare.
Okay, so one of the things that's very important, and I want you to keep this in the back of your mind, you cannot brain dump this information. You got to keep pulling it forward every day we show up, because we are laying the foundation for building this house of knowledge that I want you to walk away with. And I'm going to repeat things over and over and over again so that you can connect the dots. So this is a Part B claim, and this is for our physician services. So let's talk about what's on this claim form very briefly. So what the provider did is reported with a CPT code. These are CPT codes. Why the provider did something is reported with ICD-10 CM codes. So when we're communicating with the insurance company, instead of using words, we use numbers. So from a CPT perspective, what they did on this particular claim, the 99213 is a problem-oriented office visit. 81001 is a urinalysis. 71046 is a chest x-ray. The ICD-10 CM code, J180, is pneumonia, and R350 is for urinary frequency. So I'm going to stop sharing and see if everybody is still following me. Or if you understand, I should say, what I just went over, that claim form. Did it make sense? Yes. No. Yes. So there's another step to it, which we're not going to really get into today. But one of the things that the claim scrubber is going to do is check the CPT that we report to ensure that we've matched it up to the correct diagnosis code. For example, can we say the patient had the chest x-ray because of urinary problems? No.
No.
So the scrubber, that's one of the things it's looking for. Did we link the correct CPT with the correct diagnosis code? Because if we didn't, and we don't correct that before we send the claim out, guess what's going to happen to the claim?
It won't get sent out because it's not clean.
Well, actually, guess what? you can send dirty claims in. And guess what happens to those dirty claims?
You go in the garbage.
Well, they don't go in the garbage, but remember we talked about, so let's go back to our steps. Remember we talked about after the claim was submitted, step number 8 is that we get a response from the payer. And the payer's response could be yes, no, or maybe. If they say yes, what do we get? I know Jasmine know.
The money.
Yes, if they say yes, we get paid. If they say no, we don't get paid.
We don't.
What about maybe? Why would they say maybe?
Maybe they want to verify some information that was kind of suspicious. I don't know.
Yeah. So remember yesterday we talked about how if we report an injury diagnosis code, they want some additional information because maybe your car insurance is responsible for that claim. Or maybe you were walking down the street and the city of Chicago is responsible for your claim. So maybe just means maybe. Let's see. And they generally want some information. Okay, so we get paid. We post the payment. Let's talk about this. We charged $200. Medicare gave us our 80%. Hopefully, we've collected our 20% from the patient. If we didn't, we got to bill the patient that. But during the payment posting process, this is also when we write off that money, which is the difference between what we charge and what they allow for the service. Does it make sense based on that mathematical calculation we did earlier? Yes. So we're writing off that dollar amount. We don't get paid for it. Okay. So if they don't pay us, we appeal them. We can call the number on the back of the insurance card and find out more information. And I think that's enough for now because that was a lot of information. So everybody got the 10 steps now? These are the first 5: scheduling, registration, patient visit, coding, and then charge entry. Steps 6 through 10: claim scrubber, claim submission, payer response, and claim appeal. Okay. That was a lot. So it is now time for Power 5. Who remembers what Power 5 is?
It's 5 things that we learned today.
Yes. All right. Hit it. Dejanay, you answered first. I told you it's better to go first because whoever goes last, they are gotta cover, and you can't say what somebody else said.
For pre-registration, we had to verify their insurance to make sure that some patients don't have to pay out of pocket. There are 4 coding systems.
Okay, and what are they?
CPT, HCPCS, ICD-10-CM, ICD-10-PCS. There are 6 type of scheduling.
All right, Dejanay, that's enough. You did good. Next up.
I'll go.
next.
Go ahead.
I learned that there's 7 domains for CMA,
Mm-hmm.
which are the scheduling, intake, logistic, compliance, education, policies, and terminology. Um, I learned more in depth about the payment of co-insurance and co-patients. I also learned that most of these clinics, even though they charge $200 for a service, they only get paid 80% of it from the insurance, and they
Oh, pause.
oh
Don't box yourself into 80%.
oh right,
They
okay,
only pay what they allow. Because it
right,
could be 20%.
right, okay.
Mm-hmm. Mm-hmm.
All right, so a certain percentage from co-insurance, and I didn't know that most of these patients are not charged for their co-payment.
We're supposed to get it at the time of service. That's what our contract says with our
Right,
insurance company.
right. And I'm curious, like, why don't clinics charge when it's due?
It depends on the clinic that you go to.
Oh, okay.
Because if you are working and you have an employer sponsored plan,
Mhm.
you're going to more of a private clinic as opposed to a public clinic, and they collect that money. When you go to public clinics, their processes are not as streamlined and as efficient because maybe most of their patients don't have insurance. They rely on government funding, and so they don't. They're not as disciplined as a private pay
Mm,
clinic. So, like, remember I kept mentioning the federally qualified healthcare centers. They may not check. They may not, do it as much.
right. All right. I think that's it, right? For
Mm-hmm.
me. Okay.
Next person.
I got a question with the Medicare D with the drugs. So are those like it's just pertaining to drugs only? Like they can't go in for anything else, like with the inpatient outtakes or anything?
That's correct. It's only that part D is only for drugs. Only for drugs. Next person.
Hello.
Hello.
10 steps to the cycle, to the revenue cycle. Also going back to Medicare, 4 parts, A, B, C, and D. And with that, when you apply for, in my case, when you don't, have an employer and you apply for Medicare, apply for insurance, it's what is called market something where they put you in this like market pool or something. Because I was trying to get Blue Cross Blue Shield at one time, and they sent me to some kind of market thing,
The
which I really didn't
marketplace.
want to do.
That's
Yeah,
the marketplace.
Yeah, that's what it is.
And the
Yeah, I don't like
marketplace,
that place.
the marketplace has plans that are organized like the metals: gold, silver.
Right, right.
Mhm.
Because one plan said you didn't have to pay the premium, but other stuff was taken out. My prescription drugs were high. I couldn't go to Walgreens to get them and all this other stuff.
Mm-hmm. See,
Coding. You have what ICD 10 PCS, CPT, ICD 10 MC.
CM.
Okay, CM. I'm sorry, CM. Yes. And then you have scrubbing and response and claim appeals and all that.
Mm-hmm. Mm-hmm. Okay, yeah. Next person. I see some people left. So we got, I think, one person left. Our frequent flyer. I like getting on the plane too.
I learned about the revenue cycle steps, the 10 steps.
Hey, somebody said that already.
I know, but it's a lot of others. I mean, they basically said everything.
Okay, what you got?
the problem and preventative.
Nobody said soap note.
The SOAP, the SOP. Let me go to it. The SOAP is subjective. The S, the O, objective, the A, assessment, and P, the plan. The subjective, what the patient is saying is wrong. The objective, what the provider is saying is wrong.
All right, that sounds good, good. So tomorrow morning at 9 a.m. Central Standard Time, you will have a quiz. So you didn't get one today because I wanted you to realize
Thank you.
how important it is for you to study. So tomorrow we are going to have the quiz, and we also are going to talk about our first domain, which is scheduling. So that packet that Mr. Pugh sent you, please make sure you read it from cover to cover. All right, any questions?
What will our quiz be on tomorrow? So what will be on the things that we learned today, like everything we learned today, and then some of the stuff we learned yesterday?
Okay. So I'll have the recording uploaded in the next hour. So that same link that Mr. Pugh sent you, the recording will be sitting right there because I have it. It's a unlisted playlist, and the only way you can get to the playlist is to have the link. So don't be giving y'all friends that playlist because that playlist is only for you. So I will be uploading that other video as soon as we log out. Because we were on here for 2 hours, it takes about 10 minutes for it to generate, and then I'll upload it.
Can I get mine in the 8-track?
No. That's extra.